Yeah, so Zuranolone has dramatically changed the treatment landscape for postpartum depression. When we have a first-in-class FDA-approved medication for a challenging to treat disorder, it's really quite a big deal. And Zuranolone is a differentiated antidepressant, and that came about after about 20 years of basic science and clinical research. And that research led to the recognition that rapid decreases in reproductive hormones, especially during times of stress, like the postpartum period, have an impact on neurosteroid levels in the brain, and that can lead to depression in new moms. So it's really a pivotal change in how we think about postpartum depression and how we treat it. Yeah, so as a psychiatrist, I speak to women about hormone-related mood disorders every day in my practice. And when I explain that there's a biological cause for how they're feeling, they always give me a huge sigh of relief because women with a sensitivity to those fluctuations in hormone levels, they already know that that's impacting their mood. But I really think that the science and the clinical research had to catch up and demonstrate that for the rest of us in society to recognize it. But by demonstrating that it's biological, it really helps to decrease stigma and make women more open to receiving treatment. So I think the most important part of the discussion is that we know without a doubt that not treating a mom's depression causes significantly more harm to baby than exposure to any of the medications that we use for depression, and that certainly applies to Zuranolone. Untreated depression is an exposure, and it causes harm to baby and really the whole family. So moms have to know that deciding to treat their postpartum depression with medication is really the best option, not just for them, but for their baby. They're not putting their baby at risk by prioritizing their mental health. Risk for baby comes from not treating mental illness. So I think we as women and society in general think that emotional concerns after childbirth are normal and it will get better. But for about 20% of women, this is not the case. So there's a misconception that a mom has to take a traditional antidepressant maybe before they can take Zuranolone, and that's not the case. And it delays effective treatment, and it prolongs illness, and it prolongs exposure to mom's depression, which is harmful for baby. I think patients also think that the medication is expensive. It is an innovative, differentiated medication, and it's new, but our patients have had a very small out-of-pocket cost for treatment, only around $50. So I think there's a misconception that it's hard to access, and that's certainly not the case. So I always take a personalized approach with every patient, and I partner with mom in treatment planning, and often dads are part of that conversation. And I've actually found dads to be really strong advocates for their wives and for treatment. That helps to decrease mom's guilt and shame. I like to talk about personal risk factors for postpartum depression and her own history in terms of her struggles with depression or anxiety. I'm going to always encourage psychotherapy, but at this point, I really don't consider traditional oral antidepressants as an option for PPD. And that's because in the postpartum period, a rapid response is critical to getting mom into remission to minimize the impact on her and her baby and family. And Zuranolone is really the only antidepressant that can pull a mom out of her depression in just a few days. Traditional antidepressants are going to take weeks, 6 to 8 weeks usually, before we see an improvement in mood. And we just don't have that kind of time in the postpartum period. Yeah, I think the biggest surprise for me as a psychiatrist is that while Zuranolone isn't FDA approved for anxiety, in my clinical experience, it really can decrease anxiety pretty dramatically and quickly. So we know that with depression, especially in new moms, anxiety comes right along with it. And so seeing that improvement in anxiety is an extra benefit for moms that we treat. I've had a patient who actually, her and her husband had made the decision not to have any more children because her postpartum depression was so severe. And she didn't feel like she could go through it again. But after being treated with a medication for postpartum depression, they realized that there was an option that would work for her, and that made them open to having more children. So that's really a beautiful thing. So I think as a physician, I'm more likely to treat a disorder if I have an effective treatment available. So I'm more likely to ask the questions that I need to diagnose someone with a disorder. And it's not just me, it's my colleagues in OB and primary care that maybe have been hesitant to ask about mental health, not because they don't care, but because they have limited options to get mom the help that they need. And that's not just due to medication availability, but also just mental health expertise and the delays that it takes to get in to see someone in mental health. So I think that Zuranolone is making my colleagues, especially OBs, that are outside of mental health more comfortable in screening for depression and anxiety in the postpartum period because they know they have a treatment that the patient can access pretty quickly and it's effective. I think one of the greatest opportunities to impact rates of mental illness at scale is to collaborate. So mental health providers collaborating with primary care doctors, including OBGYNs, through an integrated behavioral health model like collaborative care. So that's something I'm really passionate about, and I'm working on as part of my role with LifeStance is to build programs that connect patients in their primary care doctor's offices with a therapist for therapy, but also it connects the OB or the primary care doctor with a psychiatrist for psychiatric consultation. We don't want to have a mom with postpartum depression in her OB's office be referred outside to a psychiatrist. It could take weeks before that appointment can happen. The OB can start medicine with Zuranolone really quickly and get mom treated. I would just like to encourage my colleagues to consider Zuranolone as the first option for treating postpartum depression. Insurance companies don't require patients to go through step therapy. They don't have to fail other antidepressants. Zuranolone is the only FDA-approved oral antidepressant for postpartum depression. So don't delay starting the medication and maybe get patients treated quickly.